Morning, students. Trying to share my screen and it says it's unable to share content. All right, there we go. So this is the end of life lecture. And as much as we would hate to have to talk about that with pediatric patients, and here I'm going to move my camera here since I'm going to be talking to you from this screen. Um, we want to go ahead and talk about it because if you work in pediatrics, there is always the possibility that you will be faced with this in your career. So your objectives are listed here, and I won't go over those, but make sure that you do kind of take a glance at that. This is covered in your textbook. Let me go back to that first screen. Y'all give me a little grace here. I've had a very difficult time trying to get this going. But there's only a very tiny amount of information in your text, and it's on page 569 and 570. So if you are interested in this topic and want to know more about it, you can go to the internet and see what you can find. But like I said, there are your objectives, and I'm going to cover these topics because I selected them carefully to help determine what we need to look at. So the first thing that we really want to talk about is quality of life. Okay, this must be taken into consideration when making decisions about whether or not to continue treatment or withhold treatment. And so we have to help the families understand what quality of life is. Um, when we talk about withdrawing care, we aren't talking about just withdrawing all care and leaving them there in the bed with no care. We can and will struggle with the decisions made about the care that's provided, but we will certainly provide care. And in some cases, we'll still continue to do curative care, even though they are in the dying process. So that's something that's a little bit different with pediatric patients. And we'll talk a little bit more about that here in a minute. So one of the questions is continuing care in this specific case, whatever that case is that you're dealing with, resulting in a positive quality of life for that child. This is something that you have to be prepared to discuss with the family. And sometimes families are determined to maintain that life even when the quality of life is gone. So let's talk about terminology. So these are the frequent terms that you'll see used. Um, Terminal illness. That is an illness that's deemed to be incurable and ultimately leading to death. We see this a lot in certain cancer diagnoses. The end of life of care isn't just for terminal illness, though. Withdrawing care is another term we'll see used sometimes due to really bad trauma or maybe at the end of a cancer journey. And the caregivers may decide to withdraw care. This may mean turning off machines and medications and allowing for a natural death without the assistance of machines and or medications. It does not mean that we withdraw all care. All right, so let's talk about DNR. DNR is an actual physician order. We have to have that. The DNR means that we will not resuscitate. We will withhold CPR for cardiopulmonary arrest, right? But the DNR define what we do and do not want to do during the dying process. They vary a lot. So sometimes it may say no resuscitation, or it may say no intubation, or no CPR, or just no efforts whatsoever. You may also hear DNI, and DNI stands for do not intubate. Some people say they may want medicine, and that's fine, but they don't want chest compressions. And there may be specific cases where chest compressions actually do more harm. So we will follow whatever is chosen. And we have to know that caregivers are going to have a huge sense of guilt when it comes to this, and making a decision to make their child a DNR. So we have to give them a lot of opportunity to discuss it. We have to be non-directive. I think I've used that term with y'all before, where we do not try to guide their decision. We have to affirm their choices and let them know that we will uphold that. We need to make sure and include in that discussion the positive quality of life. Um, and caregivers may go back and forth. And we call that waffling, where they make a decision and they change their mind, and then they go back to it, and then they change their mind again. And they may say the child is a DNR and then make them a full code the next minute. And so as they change their mind, we need to make sure that the chart does stay updated. And we have to honor that, and it's totally allowed and it's understandable. So keep in mind that you as their nurse are going to be a huge part of those discussions. The provider will be the one that really introduces the topic. Okay, so we don't want to be the one to introduce it, but we should be present when the doctor goes to talk to them. And I specifically do say doctor in this case, not provider, because a doctor is the only one that can do a DNR. So they will be the ones that introduce the topic and discuss it with the patient and family. But we should be there and listen so that we know what has been said and we can help sort the information out. You know, patients, when they go to the doctor, typically don't hear everything that's said. And the percentage that they predict that a patient understands when they've gone in and have been told bad news is about 20%. And I can tell you, I remember being in the room with a patient who received bad news, and they really were anticipating different news. And the minute the bad news came across, I saw their face turn beet red, their eyes went to the corner of the room, and I knew that patient heard not one more word that was being said. So of course I had to tune in and make sure that I was ready to discuss that. So the good news is that there's palliative care, and palliative care is known as comfort care. That is making sure that the patient stays comfortable. It's not the same thing as withdrawing care, right? We're still going to be providing care. It's just a little bit different. All right. So we want to make sure that we keep them comfortable. Sometimes that does include using more pain medication than you would think would typically be used, especially for a little bitty child. Okay. So our Make-A-Wish video is going to play for you now.
Of generous friends like you. These Wish kids have incredible imaginations. That's why when Hunter wished to be a dinosaur, we at Make-A-Wish knew we had to go big. Mammoth, monster-sized, dino-sized, to turn Hunter's wish into a life-changing experience.
We have unconfirmed reports of a suspicious animal on the loose. Take a look at this video that we...
Granting wishes takes the love, energy, and passion with.
Oh, so sorry, guys. I don't know why the entire thing did not play for us. Let me see if I could go back and get it. And we'll pick up where we left off.
Of generous friends like you.
There we go.
These Wish kids have incredible imaginations. That's why when Hunter wished to be a dinosaur, we at Make-A-Wish knew we had to go big. Mammoth, monster-sized, dino-sized, to turn Hunter's wish into a life-changing experience.
We have unconfirmed reports of a suspicious animal on the loose. Take a look at this video that we...
Granting wishes takes the love, energy, and passion of many. From Make-A-Wish volunteers, city officials, and local community members, to families and friends, and even total strangers. It takes all of us to transform the lives of children with critical illnesses. But ultimately, granting wishes starts with you. Make-A-Wish has granted more than 500,000 wishes over the past 40 years. And with your help, we can grant even more by giving $20 a month.
Okay, so that's where they give you their pitch, okay? And that's fine. I think it's a great organization, and I've seen it in use. Y'all know I talk about having done cystic fibrosis for about 3 years with LSU, Ochsner LSU, and we had quite a few patients that had Make-A-Wish dreams come true. And I have to say the vast majority of these kiddos want to go to Disney World, and of course we're going to include the entire family in that, and we'll send them whatever their wish is. We try to make that happen. Okay, so our little buddy Alan there's wish was to become a dinosaur, and anyway, they were able to make that happen, and thankfully that was done. So let's take a little bit of a deeper dive into palliative care. Okay, so palliative care focuses on comfort during the dying process. You may do this for patients who have a poor quality of life or have been diagnosed with an incurable disease. We provide symptom management and supportive care. This can also include pain management. You'll see it a lot with kids that have a chronic illness. These kids may or may not have a life-ending illness, the way you see hospice or palliative care given to an adult. So they may have chronic disease and need palliative care. Palliative care is typically on board for cancer patients, even when they have a good prognosis, because cancer treatment is so horrific sometimes. We're going to provide palliative care, even though they are expected to recover. And that is somewhat different than what you'll see with an adult. Okay. So let's talk about hospice care. So hospice care is specialized care that is provided for that dying child. And the prognosis of, having 6 months or less is what we expect, but it's not necessarily that it has to be that way in a child. So you'll notice that I say in a child quite a bit. There are a lot of exceptions to the rule when we're taking care of a child. So it doesn't mean that the actual death is expected to happen in less than 6 months, but it may be what the prognosis is. People do outlive their prognosis though. So with hospice, family members are often the primary caregivers, and that's good. They need to be involved in that child's dying days. It helps them process their grief. There is a focus on, of course, pain control and comfort. You'll hear a lot about hospice having to do with death with dignity. And we are there to support the family and provide information to them and give them updates on prognosis or disease progression, treatment options, and the side effects of those treatments, and how we may be able to help overcome some of those. We want to be aware of the child's wishes. And we, take into consideration, of course, the family, but the child is also an important part of the decision-making process in this, if they're old enough and capable to do that. In hospice care, we have to deal with personal grief. And by that, I'm talking about of the healthcare team itself. Hospice can be done two different ways too. It can be done in the home, or it can be in an inpatient setting. Hospice can lead to caregiver role strain. We've talked about role strain before and anticipatory grieving, but this is where they just are exhausted with caring for that child. And so that's when we can sometimes step back in and help in that process. So some people want their child to die at home with them, right there in their own space with their own belongings. And in that case, hospice nurses come into the house and help them care for their child. But some families can't deal with it at all, and they don't want their child to die there in their home. And they just feel like they can't deal with that. And they may feel that it changes their home for them and the rest of the family forever. So there is no right or wrong in this. They just may feel like they cannot. It is a family's choice. We give them the options, and then it's their choice so they can make an informed decision. Also, in hospice with pediatric patients, they can still do curative treatments. And in hospice with adults, we don't do curative treatments. And even if their prognosis is bad, we still do things like chemo and radiation, because sometimes those are the things that shrink a tumor that's causing a lot of pain. All right, so let's talk about how they conceptualize death based on their age. So when we think about death and dying, we have to think about our age groups because we have our own concept based on the fact that we are adults, and we've probably experienced it somewhere along the way. But an infant or toddler, the way that they experience it, meaning what they think about their impending death. So birth to around 3 years of age, they don't have much of a concept of death. They don't really process and conceptualize things yet. Toddlers do react. And we've talked about how they react to being in the hospital, with some regression. So they react to the changes that are going on with their body. There may be more changes brought on by hospitalizations or painful procedures, or things like immobilization, or the separation that sometimes has to take place from their parent or caregiver, and separation from their normal routine, their normal schedule. And, they like their routine, and that's where temper tantrums come from, when we take them out of their normal pattern of when they eat, when they go to bed, that kind of thing. So all those things can make the death and dying process a little bit harder for an infant or toddler. And like I said, there may be some regression, and we expect to see that. So our preschoolers, there are 3 to 6, well, really 3 to 5. It ends when they turn 6. They see death as being temporary or reversible. Remember, they are magical thinkers. They may act out things like jumping into the air and putting their arms out, pretending like they can fly. They may actually think that they can really take off and fly due to their magical thinking. And they're also going to mirror their parents' emotions and actions at this time too. And so if the parent is really emotional about it and having a difficult time, it will be reflected in how that preschooler will handle it as well. They may feel a lot of the parent's anxiety. They also remember how they put causation on themselves, like whatever they've done is what caused it to happen. So they may think because they disobeyed their parent or they hid something, like they stole a candy bar from the candy jar when they knew they weren't supposed to and they hid it real quick. They're going to put cause and effect together when that's not the case. So we have to remember to make sure that they know that they are not to blame for the fact that they are ill and dying. Remember also how egocentric they are. Um, they may think the separation from their parent or caregiver is a punishment. So remember to keep that in mind as well and keep them together as much as it's possible. So let's talk about school agers. That's our 6 to 12-year-olds. They are starting to understand what's going on. Okay. They know death is irreversible and inevitable, that it really is going to happen. But the younger ones in this age group may think that a dying person is just sleeping and that they'll eventually wake up. The older ones in this school age group are starting to have some fear in relationship to the disease and dying process. A lot of fear of the unknown exists, and they want to know what's going to happen, where are they going to go once they die. They have no control over this situation, and that creates a lot of fear. And sometimes that comes out as being very uncooperative. So we have to recognize that their lack of cooperation at this time is due to their fears. They're also curious, wondering what's going to happen to their body. So let's go back. I want to talk a little bit about adolescence because, they really focus on that a lot. They know that death is inevitable and irreversible as well, but they think of it as something like really distant in the future or something that's going to happen to somebody else, not them. Okay. It occurs in the distance, right? Something they think, sometimes, we talk about teenagers and feeling that sense of invincibility or invulnerability. And so they still feel that way when it comes to their own death. So if there's a sudden tragic death, um, like maybe a motor vehicle accident of a teenager or something that happens in a school setting or to a friend in their friend group or a close family member, they have a lot of trouble wrapping their heads around that idea. They feel like death is far into the future and not going to touch them or their little bubble. So when it is happening to them, they have a difficult time accepting it. They also feel isolated a lot because of it. They can't relate to their peers, and their peers can't relate to them. So they may have poor communication with their peers. And remember, that's the most important thing to them. And remember, they've already got trouble communicating with their caregivers just because of the way that they communicate. Remember, they rely lots on their peers in their relationships in this stage. So if we have a dying adolescent, sometimes they can be concerned more with their appearance than their actual death. Isn't that kind of crazy? They have increased stress from changes in their appearance, how they look, how their peers and family see them, rather than the actual dying process. So they can also experience some guilt and shame. And, they feel really bad when they see their parents struggling with emotions that are being brought on by their illness. So now let's move on and talk a little bit about, here we go, caring for the dying child. Okay, and some nursing interventions. First of all, we want to be sure to make ourselves available, right? We need to give them the opportunity to ask them questions and provide information. So we will display active listening, show them empathy, allow the family and patient the opportunity to ask the questions that they need to ask. Let them share special memories with you And if you have a special memory with that pediatric patient, share that one. Okay. We went to the celebration of life of a friend of ours that was in his 80s and had passed away. And I've known him for about 35 years. And he had told a story. His wife had preceded him in death by quite a few years, and I knew her as well. And they were in a foreign country, and something took place, and his wife said something out of character for her, but it was hilarious to him, and he loved telling that story. And so when we went to this celebration of life, I did not know his children, but we had had conversations on the phone through the years a few times. And so they asked us to share stories. And I pulled her aside and said, "Hey, your dad used to love telling this story." And she knew before I got the words out of my mouth what the story was. And she said, "Absolutely, share the story. It'll give everybody a great laugh." So, yes, if you have a story, please do share it if you think that it would be appropriate. Okay. Let me find my place here. Encourage the family to remain with the child. Okay. Especially in the hospital setting. Let them be as active in the care as possible. So, when you go in and it's time, you see that the linens need changing and the child needs a good wiping down, and you have no idea the power of that, bath or wiping. And remember always to wipe from, like fingertips up towards the shoulder and from the feet towards the groin, because it just helps with circulation. It just makes them feel so much better in that moment. But if we can give the parent that opportunity to do that for their child, we need to make sure to engage them because they're so lost in their grief. They may be sitting, staring out the window, just leaning on their elbow, and we need to make sure that we engage them as much as possible. They'll never regret the care that they provided at the end. So we need to make sure that we are providing the privacy that they need. And then keep in mind too that there's going to be a whole lot more flexibility when it comes to visitation. Okay. They're going to extend the number of people that can be in the room. They'll make it not just family. You'll find if they are in hospital, a lot of times they'll say only 2 family members at a time, please. But not when it comes to this. So there will be a lot more of, you know, laxability in the visitation. So we also need to remember how important it is to communicate honestly. Okay. So we keep it honest and respectful. We do keep them informed. We have to keep them in the know. Okay. So let me see here if I want to transition. No, let's stay on this slide for just a few more minutes. So we need to find out what their beliefs are, okay? What their beliefs and thoughts are about, the death of their dying child, and we need to honor their thoughts and beliefs. We remember that we do remain neutral, okay? Recognize and support the differences in the grieving process. Just because we expect grief to look one way doesn't mean that it's going to look that way or that that's how that parent has experienced it. You're going to find that you're going to have differences in how people present themselves because of different cultural or religious beliefs. And what their role is in the family. Like the dad may think that he has to be strong and stoic and hold the whole family together by doing that. Our mom may have to be just little Miss Pollyanna and constantly be busy and doing and lose out on the emotional end of things and the connection by trying to maintain normalcy. So we have to remember that the appearance of grief isn't always what we expect it to be, and that it doesn't mean that they are not grieving. And so we have to sometimes help them know that it is okay to express their grief. You'll also see that we make a huge effort to do continuity of care. Right now in pediatrics, y'all are probably seeing that we are not attempting that whatsoever. And it is because you have so few opportunities, and we want to make sure that you get a wide range of experiences and see all that you can. And we don't want you to go back week after week and see this one child that's in the hospital for 6 weeks because they have a neurodevelopmental disorder. We want you to get a wide variety. But when it comes to a dying child, we're going to have a very small, close-knit group of nurses that take care of them from each shift as they hand off from one to the next. Okay. Pain control is something that we need to make sure we're looking at. It is a major concern. Caregivers do not want to see their child hurting. Okay. So how do we manage the pain? Some caregivers may express concern about their child getting addicted, but we're talking about a dying child, and addiction is the least thing on our mind, okay? So we have to help them understand that pain control is more important than, the worries in regard to that. You may also see pain medication given on a round-the-clock basis versus PRN. They may also use PCA pumps, and sometimes that's dependent on the parent being able to push the button, but we really want it to be something that the child is able to use. And there's absolutely nothing wrong with using other pain control methods, such as distraction. We may, want to, of course, continue to include all five senses, okay? And we talked earlier, I think, about how hearing is the last sense to go, but we may want soft lighting, right? Because it may seem more comforting, but also I can tell you on a cloudy, dim day, I really seek the light, right? So I have a open roof on my car, and so I'll open that roof on the car to let more light in, just because it feels more positive, right? So we have to kind of try to interpret how that family is acting, and provide the stimulation that they need, whether it's darker or lighter. Maybe playing music, or even if the child had a family or a favorite video, we'll make sure that we can play that. Because like I said, even if their eyes are closed and they don't appear to be listening, they are still able to hear, because it is the last sense to go. All right, so now I think we're ready to talk about types of grief. All right, so there, anticipatory grieving, we've already touched on that a little bit. It means that the death is expected, or that it is a real possible potential outcome. Everyone knows that death is a probability, and most of the time when we think about this, we think about a child that has a terminal illness, not the sudden loss of a child due to say an accident, or drowning, or something such as that. So anticipatory grief is different than when you have a traumatic death, like an ATV accident. So it is different. Then there is complicated grief. And the definition of this is that it extends for more than 1 year following the loss. Many caregivers of children have this, right? Or close family members also may experience it, especially when death occurred unexpectedly. This isn't just sadness, it's really intense thoughts or feelings, and includes loneliness, distress. They have lots of emotions and feelings tied up in this, and there may be disturbances in their personal activities. Like they just can't continue on with everyday activities. So they've lost interest in the things that they would normally want to do. So counseling may be something that we should suggest at this point. So we kind of touched on the parental grief, but let's talk a little bit more about it here. So parental grief is the intense and long-lasting grief, and it includes secondary losses. So what we mean by secondary loss is that when that caregiver or family was thinking about all the things, the hopes and dreams that they had for that child that will never be. They imagined their child having high school graduation, or their wedding, or what they would be like as a parent, or what their adult life would be like were they going to go to college, all those kind of things. So when that child dies, whether it is anticipated or traumatic and unexpected, there is secondary loss due to the child not being able to fulfill their life and those dreams. This is very complex. It is never normal for a child to precede a parent in death. There is a lot of disruption in the family unit when it happens. The other thing is that this parent has to explain to the siblings. So we're talking sibling grief a little bit now. The parents have to explain to the siblings why their brother or sister isn't coming home. So we have a bit more time to prepare them when it's a chronic or long-term illness, but not always. So in sudden, unexpected, or traumatic deaths, the parents already have been hit with this horrendous news, and they are grieving already. And then they have to figure out how they are going to tell their other children, who they know that they're going to be breaking their hearts when they tell them the news that their brother or sister is not going to be coming back home. And so this can be hard, of course, But then you think about the impact of this, and it can be really hard on marriages and family relationships in general. Um, the siblings may, as unreasonable and incomprehensible as it is, blame the parent. They might say, well, why did you let them get their driver's license? Or why did you let them go to that party? Or things like that. So we have to help kind of navigate the waters on that a little bit. Let's see, let me take a sip of water and find my place. Bear with me a second. Let's go back. I still have a little bit more I want to say there. We talked about how the parents, one may close off, and that's fine too. We also need to find out what kind of a support system they have. Okay. I think about there's a young military couple that live one house down from me, and we have just become fast friends. Neither one of them are from here. They are not from the same area, so neither one of their families live anywhere nearby. And they've just recently moved here and they don't really know a whole lot of people. And so if something happened in a case like that, where is their posse? You know, who's going to support them? So we might have to be part of that system, okay? But families can become very dysfunctional and chaotic sometimes, and they might have been that way to begin with, because chaotic, dysfunctional families become more so in times of distress. So you may see that. There's also a little bit to be said here too of if they've experienced the loss of another child, say that they do have a genetic disorder in their family. I can use cystic fibrosis. We had siblings sometimes that passed away, and I had siblings that I cared for in CF that after the time that I left there, both of those died. And so it is very sad and very hard, but having experienced it once at least helps to some very tiny small degree. Okay. We also have to think about their culture and ethnicity and their spiritual and religious beliefs, and that may influence how they grieve. And then we talk about socioeconomic status, and I don't really see how this impacts it other than that parent may not have the choice of focusing on grieving that child. They may have to go back come Monday morning because they have to support the family. They have other children that live at home, and they know that electricity is going to be cut off next week, or the groceries will not show up on the table if they do not get back to work. And it's very difficult to turn the page, and they need the opportunity to experience that grief before they try to move on, or they never will process it. So let's talk about the stages of grief. Okay. We've all been taught, and probably you still have been, that there are 5 stages of grief. But now they're talking about 7 stages. The 5 are the denial, anger, bargaining, depression, and acceptance, as you see in that first picture. The 7 are listed there. It starts with shock and denial, followed by pain and guilt, then anger and bargaining, followed by depression, and then we begin to see an upward turn. And it's reconstruction, and that helps them work through, and that leads to acceptance and hope. So how do we support that grieving process? Okay. We want to establish a trusting relationship so the family and the patients know they can trust us. We need to encourage communication with us as the trusted care provider that they have. We want to clarify, refocus, and supply information as needed. Help the family plan for the care of that child and ensure their wishes are implemented to the best of our ability. Offer resources, okay? Arrange for hospice if that's something that they want. So some of the things that we can help them arrange are spiritual support, right? Most hospitals have a pastor on call if the family doesn't have one of their own, or like if they're relocated to a hospital somewhere other than where they live. You know, sometimes we send patients like to Mayo Clinic or to Arkansas Children's Home or Dallas or Houston. And so when we do that, they don't have their own spiritual support available. So anybody that works in that capacity in the hospital is going to be very neutral and try to meet the family's needs and just be available for them. Ooh, so how are we impacted? Let's look at that. Oh, and this is a big one. So hang in there with me, okay? We as nurses are going to experience grief from dealing with these situations. So how can we manage our own grief? We have to do a little self-reflection first, right? We have to examine our own values related to death and dying and withdrawing care. We have to consider our views on quantity of life versus quality of life. The ANA Code of Ethics for Nurses is a good resource. Our feelings could be different from the caregiver feelings. So if you have a strong stance that is opposite of the caregiver's values, then you really need to do self-reflection, and you may even need to step back from this patient and have someone else step in that may be a better suit, because it is creating for you a moral dilemma. And you do want to make sure that in all cases that we are honoring how that family feels. So it may be that you do need to step back. Um, when you lose a patient, it may be very difficult emotionally to process this. Most hospitals have EAP or employee assistance programs that will help offer free counseling. It is completely free. And they even give you time off work to attend counseling and have time for your grief if you need it. There can also be formal debriefings. So, like I talked about with the continuity of care, and you have the 2 rotating days and 2 rotating night shifts. And so you may have a formal debriefing where everybody that is present and taking care of that child for a period of time sits together and talks about what went well and what didn't go well, and how they feel, how they're coping. So self-care is what we're talking about here, and that is so important. You have to find time to do self-care, whatever that looks like for you. It may be physical fitness, okay? It might be knitting, okay? Or baking, or playing video games, or pottery, or even just journaling, taking long walks in the woods, that kind of things. And there's a great quote. I wish I could give credit to whoever it comes from. You can't pour from an empty cup. Right? So engage in your hobbies. Therapy or counseling is always a great thing. You can unpack really good things in these sessions. You may only need one. You may need a couple, but you may need it long term. Okay. You might also want to take some time off. So use that vacation time that you earn as a nurse working in a hospital situation. Take some time and maybe even go on a vacation. Another one I want to talk about is volunteering. And boy, I really encourage that one. You cannot be out there doing something good for somebody else and focus on yourself. It is just a great opportunity to do something good, and it definitely helps make you feel better. Okay. Professional support. This could be your peers at work, or maybe management or administration, or former classmates. Nurses are also allowed to attend the funeral. That's important to know. Okay. You're really encouraged by the hospital to attend that funeral if you want to do so. And you're also allowed to maintain appropriate contact with the family. So that's good. Remember that we do have a professional relationship with them. We have become close to them, but we also need to remember that it's in the capacity of our profession as a nurse that we will maintain that contact. The biggest thing I need to say here is that you need to avoid anything to do with social media, okay? Do not put any kind of post out there about anything to do with the death and dying process, anything to do with that patient's condition, or like the disease that they had. Anything that you put out there is going to be taken as something about their child by that parent. They are hyper focused on their child, and they will take anything that is said and interpret it as though it is about that child. So we want to make sure that we don't put anything out there like that. Be sure and check your hospital policy as well. So the dying process. You may not have someone actively dying in that very moment because it is a process. It may take some time. Most of the time, our care is going to look like the care that we would give any chronically ill or seriously ill child. Okay, we want to provide a comfortable, peaceful time for the child and the family with minimal disruptions. So, what am I saying here? We want to cluster our care, right? We are not going to go in there every 5 minutes. We may even ask that housekeeping and the techs and everybody else allow us to be the ones that care for that child. That may mean that we go in there and we are the one that empties the trash and does the vital signs and provides the tray and does our assessment all at the same time. So we do want to cluster it, okay? Um, but then we don't want to overwhelm them with too many things going on at the same time, right? So we won't bombard them. If you've never been with somebody actively dying, it is hard. It is emotionally difficult, and it is a process that sometimes is very wearing on you over a period of time. So let's talk about the physical manifestations. What does the dying patient look like? Okay, they often have a sensation of heat, but their body feels cold to the touch to us as the care provider that's touching their body. And you'll see this in the fact that if they're able to, they'll complain about being hot, or they will be shoving the covers off of them, and you'll pull the covers back up, and just minutes later you'll see that they've been able to wiggle out from underneath them again. They do have a decrease in sensation and movement in their lower extremities, and that makes sense, right? Because their blood is going to be shunted to their core. So as that happens, there is a loss in sensation in the extremities. Like I said before, hearing is the last sense to leave. They'll start getting confusion or showing signs of loss of consciousness as well. They do have decreases in appetite or thirst, or really, truly both. They may have some swallowing difficulties just because they've lost the ability to coordinate all that. They probably will lose bowel and bladder control. It's just because everything is shutting down, okay? They do become bradycardic, and then that leads to hypotension, right? So when they're actively dying, we expect that to happen, right? The heart is beginning to slow down, and as that happens, it's doing less of a job of perfusing the extremities, and so the blood pressure does become lower. They become hypotensive. They become cool to the touch, and that is all just physical manifestations of the fact that they are in the dying process. There may be just differences in respirations. We've talked about that in the past. In second level, I'm sure you are very familiar with the Cheyne-Stokes respirations. And that is a atypical pattern, and shallow breathing, and then maybe periods of apnea and then panting, almost like we described the infant's periodic breathing. I thought I talked about the baby right there, but I don't see it. Interventions after death. Okay, so we do need to allow the family to spend as much time as desired after death with their child. Of course, check your hospital policy to see if they have a policy and what it is. Most hospitals do allow for time for that family just to spend time with that recently deceased child. So you want to prepare the family for changes in the body after death. The child may be cold to the touch, and I would say you should expect that. They may be pale. They may also be a little blue around the lips. In infants, here's where I talk about that. They sometimes have some pooled blood, which makes them look like they are bruised. And then, of course, like we said, they may lose control of their bowel and bladder. And then they may even emit gases from either end. And that can be very startling if they don't know that it is a possibility. And it even triggers to them the thought that maybe they actually are still alive and that we're just calling it too soon. Okay. So we need to let them know that that is normal. Then also they may want to rock or hold their child, or even just climb into the bed and lay beside them and hold them, whatever it is that they need to do. In OB, y'all probably talked about this a little bit. So if they have a stillborn infant, we're not just going to whisk that baby away. We're going to clean that baby up just as though it is a living child, and we will dress that baby in the same thing we would with a little cap, and we'll allow the parents to hold that child and spend time with them. They are trying to process, and we have to realize that that's what's going on. So we will remove any kind of tubes and lines unless the coroner says not to do so. And most of the time they do allow you to do that. But we're not going to do like this massive cleanup, right? We're just going to try to make them look a little bit more like they normally would. We're going to include the siblings, okay? If we try to, spare them or keep them away, they may have a harder problem processing the fact that their sibling is deceased, and they will struggle with grief a little bit more. We can remain with the family though. We don't have to leave the room, right? So even when all of this is going on, we can remain with them, unless they ask us to leave. And if they ask you to, then you do need to just give them some privacy, and that's understood. We are part of their support system, though, right? So if they ask you for a hug, you can give them a hug, if you're comfortable with that. If they ask you to pray with them, you can do that if you're comfortable with that. We can answer questions, and we can just be there for them. We may ask things like, can I call someone for you? And they may ask you things like, can I pick her up or can I hold her? And we can inform them that that is all okay. Of course, we're going to be including, I'm sorry, guys, the making resources available to them. And that might be the chaplain or other things. So you also want to know that sometimes the family wants to participate in the postmortem care, and that's okay if they do. Like cleaning and washing, just like they would bathe them if they were still alive. And refer to the patient by name, okay? They're still that same person. Use your child life specialist if you have one. They do have special knowledge for dealing with the grief. They may collect locks of hair. They may make prints of the hands or feet or their lips. Or I've seen them, do a plaster cast of their hands and other things like that. So utilize all the things that you have available to help you in this process. Okay. Whew, organ donation. All right, y'all hang in there with me. We are almost through. So organ donation. This is a separate conversation from the discussion of impending death or dying. And let's talk about what brain death is. Brain death is the time of death. Okay. So in cases of organ donation, even though we have established the fact that that child is brain dead, they may be on life-sustaining support, right? And if we are going to procure the organs, it is a process that takes, I believe, 24 hours, y'all. I'm not going to ask you that, so don't worry about trying to find that information. But it does take some time, and I've been involved with that as a student, y'all. I had a 19-year-old guy, oil field worker, that died very unexpectedly to Tylenol toxicity. He had taken the expected dose for 4 months because he had a bad tooth. And every time he'd come in from working on the oil rigs out there in the Gulf, it was his intention to go to the dentist and get his tooth fixed, but he got sidetracked by the friends and family that he had, and just all of a sudden it was time to go back out on the oil rig, and he went back out. And unbeknownst to everybody, this bad tooth had him taking Tylenol as prescribed, every 4 hours, and over a period of time, it did build up in his system, and he went from perfectly normal to hot as a pistol. His heart rate was in the 160 to 180 range, and he was basically comatose, and they got him in the hospital. It took him days to figure out that Tylenol toxicity is what took his life. But being a young, healthy man that he was prior to experiencing that, they definitely, were interested in talking to the family about organ procurement. And thankfully, they did agree to do that. And so the child was, or the young man, kept alive for a period of time on the ventilator and all. So the organ donation conversation, though, needs to be something that is not initiated by us. It has to be initiated by the organ procurement agency. Sorry, I've talked too long at this point. So we will consult them, and it usually takes place when the Glasgow Coma scale becomes 8 or less. Okay. The family needs to be informed and educated about it, and LOPA is who we have here in the state of Louisiana. And all expenses are covered by the recipient, and it is still possible to have the open casket funerals. Okay. Let me see if there's anything else I want to make sure to say to you in regard to that. I think that's really all I wanted to cover there on that, but you just need to know that it is not your role to discuss organ donation. It needs to be handled by somebody that knows how to have that conversation, even if you have been exposed to it before. So that's the end of our discussion on that, other than I have this absolutely fantastic video for you. I'm going to play it. And then I have one more slide. Make sure you don't click off until you see the final slide.
You deserve the best. At Harbor Freight, you can afford it. We design our own tools with performance and durability in mind, and hire the best engineers to put them through their paces. These tools get tested for countless hours, and if they can't stand the test of time, they don't make it onto our shelves. Performance, durability, affordability. Only one place does it all. Whatever you do, do it for less at Harbor Freight.
Sorry, guys.
Diagnosed with Crohn's disease and struggling with your symptoms? It's not too soon to talk to your doctor about Entyvio.
There. Just don't let the lights go out.
He comes and tells me that I gotta leave. Your body is the enemy. What you lie, me beat from your heart gets me through the night. That's my alibi. Say this. Go out, don't let the light go out. Don't let the light go. Don't let the light go out. My knees open, my don't let the light go out. Don't let the light go. Don't let the light. Light out. Don't let the light go out. Don't let the light go.
All right. So there is the end of life consideration on 1 Minute Nurse. And then watch that video and do the practice quiz for supplemental content. All right, thanks, guys.